My name is Kemal Erkan. I'm the chairman of American Surgery Center, and I have Dr. Isaias Irgau with me, our president for CHRIAS.
So let's start with the one on the top center, which is the sleeve gastrectomy. That's the sleeve gastrectomy. Now, I would like to clarify one thing, Kemal, that comes up often and often, right? And people think that when they hear sleeve gastrectomy, they actually think about a sleeve-shaped device that is placed to envelop the stomach. They think that that's what we're doing. And so I find patients coming to me and say, hey, doctor, can you give me the sleeve? Can you put a sleeve in me? Thinking that it's a device. Well, actually, that's a misnomer. It's not a device. The sleeve actually describes an actual procedure whereby we're actually cutting the stomach in a certain way, and we make the stomach a lot smaller than its current size.
We were also making that, Dr. I remember with the sleeve, I thought we were cutting it and then just making a sleeve for a long time. Until
That's
I
right.
like, oh, okay, that's not the case. So
that's right. So in a way, it's a confusing name. It just tells you that surgeons don't have much imagination when they name their operations, right? They call it the sleeve because the remaining stomach looks like a shirt sleeve. It's tubular. It looks like a banana, but it's not a device. It's a procedure whereby we
actually don't name these. So we should have fashion designers should.
That is true. That is true. Maybe we should put it out there before naming a new operation. We should have people compete for finding a name. So going back to the sleeve, as you can see, the before and after, you can see that the stomach has now been divided. There is a much smaller stomach. This actually happens to be by far the most common and really popular procedure that we perform by far. It is very effective. The weight loss is excellent. And also the long-term implications of this procedure are not as drastic as other procedures where we have to do some kind of bypass of the intestine. And that's why it's really so popular very often. So exactly. So it is a procedure that in our center, the American Surgery Center, is actually performed more commonly as well. And it's an outpatient procedure where people have their surgery and go home the same day. But it is still bariatric surgery, which means that the actual preparation for the surgery has to be rigorous in terms of selecting an appropriate candidate, but also preparing the patient for success by having them interact with our multidisciplinary team, including our dietitians, psychologists, and other physicians as well. And all that preparation is, of course, coordinated by our wonderful care coordination team that meets every day to follow the progress of our patients. The sleeve gastrectomy, although we are removing a big portion of the stomach, it's still incisions, very small incisions, about 4 or 5 of them. And we are able to squeeze out that big portion of the stomach through one of those incisions as well. The next procedure we're going to discuss is the gastric bypass.
Before we go to the next, on the sleeve,
yes.
From the part that we remove on the stomach, is there any part of the stomach that's different than the other side? Like the part that is removed, is there anything that's different than the other side that's remaining?
Absolutely. That's actually a key question, Kemal. That's absolutely right. So the reason we cut the stomach specifically on that portion and remove that portion of the stomach is very important, because the portion of the stomach that we remove, first of all, is the most stretching portion of the stomach. It is that part of the stomach that really accommodates food without increasing the pressure on the stomach. So we don't feel the pressure even by eating a lot of food. So it's very accommodating. It's almost like a balloon. It kind of stretches and stretches as the stomach is filled. So that is one. And the second point is that many of the cells that actively participate in communicating with our brain to tell our brain when we're full and we're not, where we're hungry, actually reside in that portion of the stomach. And by removing those cells, that portion of the stomach, actually, we remove the influence of those cells on our brain, and we become less hungry, and we are less likely to search for food frequently. So very, very important actually to remember that. And then the portion of the stomach that is left is a lot stiffer. It doesn't quite accommodate quite as easily the food.
I just want to kind of repeat that in a maybe different way. So
Yep.
on that part of the stomach, this gut connection to the brain, the only way that our brain knows that we are hungry is because of the communication that we get with the cells. So that those cells are on that side of the stomach, and we are removing that.
Yes.
And then that's not only making the stomach smaller, but also the communication is also cut off.
Absolutely.
Right?
Absolutely. Absolutely.
So,
Absolutely.
Because that's many people, they understand it as like, oh, it's just like cutting the stomach, but that's not the case.
Absolutely. We are actually impacting very important metabolic changes, right? Our metabolism is the process that determines our energy balance. So our metabolism is fundamental in how much food we seek out, right? And how much energy we consume, right? That is an extremely complex process, but the digestive system and the brain actually play pivotal role in that. And by doing this surgery, we actually impact that metabolism in a beneficial way. That is why, Kemal, very interestingly, regardless of how much weight the person is losing, we see so much improvement, for instance, in the control of blood sugar after this surgery, right? Patients who are diabetic are much better in controlling their blood sugar, sometimes even getting off their medications after these procedures. Similarly, patients who suffer from high cholesterol, from high blood pressure, because the metabolism is impacted in a beneficial way, we see great improvement. In fact, because really we are impacting metabolism so much, Kemal, our society, the one that you and I participate, the American Society of Bariatric Surgeons, actually a number of years ago changed its name to now being called the American Society of Metabolic and Bariatric Surgeons. That's why we are called ASMBS now. So this is to show that we're not really changing the digestive system to make the stomach smaller so that the person eats less, which is true also, but that's a very simplistic way to look at the results of bariatric surgery. It's much more impactful from that point of view.
Absolutely. So next procedure is bypass.
The gastric bypass. The gastric bypass really is the procedure that bariatric surgeons actually refined very, very earlier on when bariatric surgery was really at its inception. And with with gastric bypass, actually the changes are far more drastic compared to the sleeve gastrectomy. As you can see in the before picture, you have the food pipe, you have the stomach and the intestine. In the after picture, you can see that the stomach has been divided now really high up so that there is a very small portion of stomach that we call pouch that is still connected to the food pipe, but the rest of the stomach, the larger portion of the stomach, is totally disconnected from that food pipe area. Right there, absolutely. Now, we have disconnected the stomach. We have to find an outlet to that little stomach. The food that comes from the food pipe and enters in the little stomach now has to find its way to the intestine because that way has been interrupted when we cut the stomach. Well, we re-establish the continuity by actually cutting the intestine below and bringing up one portion of the intestine and connecting it with this little stomach to create what's called a bypass. That's why it's called a bypass. We're bypassing a large portion of the stomach and that early portion of the intestine. So this procedure has implications because not only now we're making the stomach that receives the food far smaller, but we are rerouting the food way away from that early portion of the intestine, which happens to be one of the most active portions of the intestine when it comes to absorbing nutrients and absorbing calories. So it's a very impactful procedure in terms of the weight loss and in terms of the impact on the metabolism of the person. But also because now we have really drastically changed the route of the food around the intestine, there are implications long-term in terms of vitamin deficiency, in terms of potential for the intestine to twist and things like that. What we have found in our studies is actually that weight loss difference between the gastric bypass and the gastric sleeve is not as great as it is to be thought of. So to just seek the gastric bypass because one wants more weight loss compared to the gastric sleeve does not seem to be that important. There are, however, situations where we say the gastric bypass is a better procedure compared to the sleeve and vice versa. Now, which procedure ultimately will be better for a patient, Kemal, as you and I talk very often, is best determined during the consultation. And the consultation is where the interaction between the bariatric patient and the surgeon occurs when, you a session like this one, and we have other seminars as well, as Kemal mentions. But then you have to come as an individual for your consultation, where it's going to be just you, the surgeon, or just you and the surgeon and members of your family, if you wish to bring them. And what we do then is the first part of the consultation really is to uncover your medical history. We look at the past history, we look at the struggle with weight, and we look at things that have been done in the past. And then together we can decide as to what is the best option at that time. And very often patients may not be totally certain as to which procedure they may want, even after the consultation. But then the idea matures through their interaction with our multidisciplinary team, as the bariatric coordinating team takes them through the various specialists and they learn more. Then which procedure might be better for them obviously matures in their head over time.
I think Dr. One of the issues that I see as I mentioned earlier, other than my responsibilities from the surgery center, I have accountable care organization, and we do the population health management. And right after our bariatric case conference, I have the accountable care organization case conferences, and the treatment for the obesity is lacking. It's lacking from primary care level. It's lacking from the patients. I think the way that patient may be, their understanding what obesity does. It's more like the look versus this is a chronic illness. So what type of surgery is not the first or the most important question. The question is like understanding this issue first, and then understanding and accepting the problem first. So then, because there's enough time to decide which procedure you are going to go to, because regardless of which one it is, if you have one of the Medicaid products, there's 6 months of the nutrition, and during that 6 months, we can decide together which procedure would be the right one. But you don't have to decide which one it's going to be in the beginning, right? So
absolutely. I mean, that's a great point, Kemal. You see, even among bariatric surgeons, very often we spend too much time discussing which procedure is going to give an extra 20-pound weight loss, or is going to resolve this comorbidity earlier. Well, we have effective procedures.
Yeah.
We have very good procedures, right? That do the great part of the job that they're required to do, which is to help people lose weight effectively. Our problem is not necessarily having the more perfect procedure. Our problem really is convincing the vast majority of patients who struggle year after year, decade after decade with the weight that continues to pile up, right? And I have a 45-year-old patient who comes to see me, Kemal, with a body mass index of 50, which is having 120, 150 extra pounds in their body. And I talk to them and I say, look, how will you be able to carry this and more extra weight in 10 years' time, in 15 years' time, in 20 years' time? It's going to be virtually impossible. And the patients know it. They say, look, this weight is going to kill me. I know it, doctor. So they understand. So our challenge really is to continue doing sessions like the one you're doing, Kemal, to convince people that there is an effective treatment with obesity. There is no reason for them to suffer year after year with the weight and with the diseases related to weight. We do have excellent procedures that can take care of this. And we have refined bariatric surgery now to the extent with programs like the ones we have at the American Surgery Center. The safety level is so high, Kemal, so high. There is actually virtually no surgery that goes through such a thorough preparation compared to bariatric surgery at all.
But also, the other thing that, although we are trying to get these patients ready for the surgery, throughout that process, although we do the population health management on the ACO side, if you look at it, what we do with the multidisciplinary approach here, we get the A1C, we get the hemoglobin, we get the TSH initially, right? So then we get the dietitians. And then that happens in certain discipline and the standard is pretty solid. So
Yes.
it
Yes.
provides a really good quality of care for that patient, even for the primary care. Foundation of the primary care is actually happening in the bariatric surgeons program.
Yep.
So I own a primary care office. So
Yep.
when I say this, I maybe, some of my primary cares will be upset with me, but that cannot be done any better than the way that we are doing.
Absolutely.
Because all
Absolutely.
those things are being, because sometimes patient doesn't do X and then we're like, no, you have to repeat it, because we don't let anything go to the next level if they don't complete it. If the
Absolutely.
even
Absolutely.
from the psych standpoint, from the
Yep.
EGDs, from the
Yep.
cardiology, sleep
Yep.
apnea, all those things are being addressed. So the safety standpoint is not the issue, but the type of the surgery, there's plenty of time to decide. But this, because I was just recently in Turkey, and when we talk about what we do, and some of our friends, they watch these events, and the understanding of the perception of the bariatric surgery is still limited.
Yes. Yes. Very much so.
Cutting stomach. Well, it's not cutting stomach. These patients, they are chronically ill, just like the patient with diabetes, just the patient with the heart disease. It's a disease. It's not like a choice. No one wants to be morbidly obese. This is not a choice. So we still want to, of course, put these type of procedure options, the education out there, but it's not the main decision that we need to make in the beginning. Now, Dr. Irgau, there are some less invasive procedures, as you mentioned. And one of the things that we did, I think we are the first one who operated the gastric balloon. And I think you are the first one in Delaware, or maybe in the East Coast, right? So
yeah, our practice at least. Yeah, definitely.
So, well, you were on TV actually. So we did this. Then this is not for the higher BMIs, but this is an option. Now, in my family, the wedding is coming up. So and I was just thinking about this. So there are some individuals who may benefit from it. So can you talk about the balloon a little bit?
Absolutely, absolutely. So with the gastric balloon, essentially, it is really the least invasive procedure we have right now because, as I said, there is no cutting of the skin. It's all done endoscopically, right? The person takes a nap. We introduce a camera inside the stomach, and then we are able to deliver the balloon, which comes deflated, right? It's not inflated. Otherwise, it would not be able to go through the mouth or through the food pipe. It comes deflated, and then we position it, as you can see, inside the stomach, and then we inflate it. Okay, we fill it up, right? And then as the balloon fills up, it occupies a good amount of space in the stomach, and it does have some weight as well. That creates a sensation of fullness, right? The person will feel as if they've had 2-3 Thanksgiving dinners, right? They will really feel full. And the idea is with them feeling full, they will be consuming less food, and that's exactly what happens. So with the balloon, clearly it's a reversible procedure, right? Because we have to take out the balloon after 6 months, and removal of the balloon by itself is the same procedure, which is the person takes a nap, and then we do endoscopy and remove the balloon, and it's totally reversible procedure. The weight loss with the balloon, as I said, is anywhere between 20, 25 to 40, 45 pounds, depending on the person, their commitment, and so forth. Like all weight loss procedures, obviously there is going to be a range. In terms of the potential drawbacks, people may have some nausea or even some heartburn, particularly in the first week, and then we really have to watch them closely to make sure they don't become dehydrated. The vast majority of patients do very well. As a precaution, we put everybody that has a gastric balloon on an anti-acid medication to reduce the chances of irritation of the stomach or even ulcers in the stomach. And by far, the vast majority of people do very well. Probably the complication that people worry the most is maybe deflation of the balloon and then migration of the balloon down in the intestine that would potentially cause bowel blockage. That is a very rare event, but we do have ways to also protect the patient from that because we put a special dye alongside the fluid that we use to inflate the balloon. And if there is a leakage from the balloon, that dye will be actually reabsorbed by the lining of the stomach and then excreted through the urine. And people will be seeing colored urine, green urine or blue urine. And if that happens, obviously they can let us know and we can promptly remove the balloon before there is any concern for bowel blockage. But even that, that's not a very common procedure. It is currently a procedure that is not covered by insurance, and therefore people who have the balloon pay out of pocket for the gastric balloon.